I am going to present my study on intraoperative injection versus sponge applied mitomycin C during trabeculotomy 1-year study. No financial interest. As all we know, the major cause of failure in glaucoma filtering surgery remain episcleral fibrosis and the conjunctival scarring. Various studies demonstrated significant enhancement of success rate through intraoperative use of MMC. The time-tested route of administration of MMC is via sponge soaked in it, and this sponge applied to the subconjunctival space. Subconjunctival injection of mitomycin C instead of the sponge is recently being studied as an alternative. So aim of our study was to determine the safety and efficacy of intraoperative MMC versus sponge applied for trabeculotomy. Material and method. Our study was randomized, prospective, open label, interventional aimed at the comparing the two treatment modalities of mitomycin administration in TRAP surgeries. Institutional Ethics Committee approval was taken. Patient who underwent TRAP surgery between January 2016 to January 2017 in Glaucoma Service Arvind Hospital, Tirunelveli were included. The 44 eyes of the 44 patients were enrolled in this study, randomized into the two groups, TRAP with injection MMC with TRAP with sponge MMC. Computer-generated table was used for randomization. 2 patients were excluded from the study due to the lack of follow-up. All surgery were performed by a single surgeon. The patient who had uncontrolled primary or secondary glaucoma on maximum tolerated medical therapy suitable for trabeculotomy were included in the study. Patients who were lost follow-up, any other ocular disease, and any intraoperative serious complication were excluded from the study. To prepare the 20 microgram injection, we used the MMC 0.4 mg per ml and 0.1 ml of the MMC diluted with 0.1 ml of the xylocaine, and the total solution become the 0.2 ml. Out of it, the half of the solution is injected with 30 gauge needle 6 to 8 millimeter away from the limbus and spread posteriorly to the anticipated flap location. And when we inject, after injecting, we close the wound with the cotton applicator and wait for around 3 minutes and spread posteriorly. And similar concentration of MMC was used for the sponge group, and rest of the surgical procedure remains same in the both group. Complete success, IUP between 5 to 18 mmHg without IUP lowering medication. Qualified success 5 to 18 mmHg with medication, and IUP failure was defined when IUP less than 5, more than 18 with more than 2 glaucoma medication, required surgical intervention, and any other serious complication. So all statistical analysis were performed in this data. P-value less than 0.05 was considered significant. So in the demographic data, it's almost not significant, almost similar. The P-value is not significant, age and sex. Coming to the diagnosis, the common diagnosis in injection group was PACG followed by POAG, then the PXF glaucoma. Look into that in sponge group, more common is POAG followed by PACG and PXF glaucoma. Look at the IUP control at the 1 month, 3 month and 6 month, almost similar in the both group. But at the end of 1 year, we found that injection group has a little lower IUP in compared to the sponge group, though that is not statistically significant. So the IUP drop was 12 mmHg in the injection group from the 28, while in the sponge group it was 15 from 25.8. So the mean number of anti-glaucoma medication reduced 0.38 from the 2.4 injection group, while 0.91 from 2.3 in the sponge group. So the best character is visual acuity remains same at the pre-op and post-op at the end of 1 year. Kaplan-Meier survival graph shows there is no significant difference in between the injection and sponge group. So these are the few photographs of sponge group and the injection group. So sponge group shows the localized, thin and pronounced avascular bleb, while in this injection group is a less pronounced, diffuse and less avascular blebs. So looking at the complications, a more number of intervention is required into the sponge group, like laser sociolysis, 5-FU injection, encapsulated bleb, and correlate detachment found in the both series 1 case, which resolved conservatively. Coming to discussion, the mean IUP drop was 58% in injection group versus 46% into the sponge group at the end of 12 months. In our study, there was no difference in IUP and number of anti-glaucoma medication between injection and sponge application. This is in contrast with the report of intratenant injection of MMC during trabeculotomy that showed the injection group had lower IUP and need of fewer medication. Our study shows the efficacy of injection of MMC comparable to sponge with less need of visit and intervention. Overall treatment success was MMC group at the 1 year was 90.5% compared to the 87% sponge group. So the sponge showed the whitish bun, often due to the overdosing of mitomycin C, lead to the avascular thin bleb, while injection group shows the more diffuse, less avascular in compared to the sponge group. Another advantage of using injection as a sponge application, MMC is a predictable dose of MMC is delivered. And our studies shows that the injection of MMC is safe with fewer need of post-operative 5FU intervention and burden of visits. Limitation is a smaller sample size, short-term follow-up. In conclusion, the injection of MMC may be safe as an effective conventional sponge application of MMC and TRAP with comparable treatment outcome. However, the studies with longer follow-up period are needed to evaluate the long-term side effect of subconjunctival mitomycin C. Thank you.